Hello, good morning.
Morning, how are you?
Fine. And you?
I'm good, thank you.
That's good. So I've set it to record.
And yes, shall we continue with yesterday?
Sure, no problem. Can you see the slides yet?
Not yet.
Not yet. Can you see them?
Yeah, I can.
Oh, good. That's excellent. So let's continue from here. Normal salivary gland. And you can see on the right-hand side here, there's lots of mitotic cells undergoing mitosis, of course, to produce the secretions. And here we can see some fracture of the tissue due to sectioning. But the various channels are interesting. This is that nice normally formed. There's a lumen in the middle. The cells around the channel are normal conformation, no pathology. And there's a bit of storage as well in the salivary gland in terms of lipid droplets. So these are the fat droplets here that have been stored. And that just gives mass to the salivary gland. But this is a good example of a functioning salivary gland, no pathology. We move on to it. Reason it's a bit slow. Then we got this gastritis, and it says it's undergoing atrophy. Now, atrophy is a condition whereby there's cell shrinkage and eventually death. Could be for a number of reasons. Could be due to, as we said before, cancer. Could also be due to blood clots that prevent the nutrient exchange within the section of the tissue. It's not very clear to see the pathology as such because we need a higher magnification. But what your professor is trying to say is that the groups of sections in the tissue that are separated. So this is a section here, another section there, separated by connective tissue. Some good connective tissue there. but the atrophy means that the number of functional cells decrease. So overall, there's some areas like this area here where there's less functional cells left. Okay, and smaller areas where secretions are produced. I think he mentions that smaller gastric pits. Yeah, smaller gastric pits. So this is indeed in the stomach. The stomach will be producing less secretions, less acid, hydrochloric acid, and less pepsin. Okay, so the inflammation could be caused by bacteria or could be caused by an ulcer. So we move on to the next bit. And if you've got any questions, please don't hesitate to ask. Here I've got an example of inflammation in terms of there's lots of cell debris that's accumulated in this area and less of the pits, less of the luminal structures. That's due to the influx of macrophages in particular to try and fight off any bacterial invasion. And the the branching of these pits is quite interesting as well. It calls them the fovulae or foveolar hyperplasia. Well, why is it hyperplasia? Well, because the size of the lumen is decreasing. You can see it's sort of shrinking. So probably a good size of the lumen, but here it's sort of shrunk a bit. in its size. So it's kind of like shrinking as a result of the inflammation. Towards the bottom, though, there's some good examples of healthy tissue. So there's a good lumen there, good lumen right here at the bottom. It's normal. With time, of course, if it's an ulcer, you get lots of fibrous tissue accumulating. So to try and it grows around the lesion, if you like. The fibrous tissue is beginning to form up this side here. Perhaps we can look at this area in terms of the magnification. This fibrous tissue is starting to form in this area. If we had differential staining, we could see the different types of tissue as well. Excuse me. But here's the example of the fibrotic tissue migrating into the area of inflammation. And notice this area is full of cell debris. See, all this area here is cell debris. So lots of white blood cells, lots of macrophages in there. The size of the lumens in these areas here are reduced as a consequence of this inflammation, so hence less ability to secrete enzymes and hydrochloric acid, for example, if this is occurring in the stomach. So yeah, he mentions lymphocytic inflammation, certainly. Yeah, there'll be lots of that, secondary lymphocyte attack as well. And the wide lymphocytic aggregates. These would be occurring in this area, the darker purple, yeah, of this area of inflammation. The darker area would be the aggregates of the lymphocytes. Now, with too many lymphocytes, what you get is the death or the destruction of cells, because they're trying to destroy cells that have kind of like been damaged or infected. And as a consequence of that breakdown or digestion of the dead cells, you get the aggregation. Okay. This thing here in the middle is just an artifact from the staining. Okay. All right. And here is the bottom of the ulcer. Yeah. So it is an ulcer. Fibrotic tissue trying to surround the area of the ulcer. I can see some lines there from the sectioning. It's not part of the pathology, but there's not a lot of cellular debris here. But what we can see more is the sloughing of the wall. The wall is breaking down, if you can see that. And as a consequence, the digestive juices are going to start also attacking the rest of the normal sort of granulation tissue, if you like. Fibrinoid necrosis is also beginning, and it tends to start with the darker areas, little patches there, there. Some little patches dotted around. You need a high magnification for it. But as the cells start to die, so they necrose as well. So there's quite a lot of atrophy here in this particular section. It looks like quite an extensive ulcer as it's progressed deep into the granulation zone. So it looks like it's been there for quite a while in this patient.
Why is it dark red like on the left-ish part?
Dark red, okay. This is a consequence of bleeding. This is a consequence of capillary bleeding, and also a mixture of cellular debris as well. So there's some clots there, clot formation. That's the main reason. Okay. Any other questions? Any other questions? No?
There's like a white line sort of streaking across the middle.
This one.
Is that of any significance?
Oh,
The one below it. So.
This one.
Yeah.
Now that's an artifact of the sectioning, it looks like to me, the sectioning of the tissue, because the hard area and the softer, weaker areas, when you cut the tissue, it can sometimes tear it. So the blade would be coming this way, the blade, you cut in the section. So I would
I see.
say this is because it's such in a straight line. It's more the sectioning of the tissue. Yeah, yeah, yeah.
Okay.
Here's a nicer example, more magnified, where we can see more of the degradation of the tissue. And I like the difference. We can see the fibrous tissue there, massively impacting the granulation zone, but the necrosis is becoming more evident. Now, the breakdown or death of cells causes lots of little spaces, and you can see these spaces here forming, and eventually a big area forms. Before, when we saw the last slide, we saw these little dark bits, but now it's magnified, we can see them a bit more clearly. So with necrosis, you're getting what's called the atrophy of the cells, they're decreasing in size, and you're getting more space forming as a result. Lots of cellular debris as well due to the death of the cells. Eventually, this whole area is going to slough off, it's going to break away, and into the stomach space, if you like. Yeah, nice, that's a very good slide. Okay. Right. The edge of the ulcer has been magnified for us, and we can see the total breakdown of particularly because it's a rough border, it's become very rough. See, the destruction of the pits, the various pits. Yeah, there's once a gastric pit there. There's once an example one, but it's broken mostly down. This one is almost finished, broken away. And the whole lining of the stomach is deteriorating rapidly. There's some bleeding as well. Excuse me. Some examples here of blood vessels. Eventually these will rupture and cause bleeding. Yeah, and some of the fibrous tissues beginning to appear at the bottom here, and over there as well, as it moves towards the edge, the rough edge of the ulcer. Now these straight lines are, of course, the sectioning artifacts, and they cut the slide, the tissue on the slide. Very nice one here. The inflammation is quite evident here. And he calls it hyperplasia and dysplasia of the stomach mucosa. The dysplasia means the disrupted function. The function is being destroyed, if you like, displaced. The roughness of the mucosal lining is very, very evident. There are lots of exposed tissue. Okay, normally this would be a round, curved like structure, but it's being eaten away, if you like. There's also the formation of quite a lot of spaces as well. So the ability of these cells to produce their secretions has been lost. And vascular congestion is occurring as well in terms of as the cells break away, the blood vessels are getting closer and closer and beginning to form clots. You can see one example there. One example is there, the vascular congestion. Other examples up here. You can see towards the right, you can see the fibrotic tissue, the fibrous tissue trying to migrate to the surface. Here, probably we've got a nice example of still a bit of healthy tissue there, okay? Still a little bit healthy, but eventually it's going to be degraded, as this part is actually a lot of loss of the cells there, a lot of atrophy. Yeah. Okay. Good. Liver cirrhosis can be caused by a number of things. One example, of course, is alcohol. The central veins are really important because they deliver the correct quantity, the volume of blood to the bile caniculi, and the interlobular veins are very, very important, as well as the arteries. So we've got some here, delivering the nutrients to the highly metabolic hepatocytes that form these roundish sort of structures within the liver. But with cirrhosis, you get lots of what we call first fibrous tissue, and then later you can get lots of lipid deposition in the tissue. So if we look here, you can see some fibers forming here. There's a lot of fibers there. Now, normally you wouldn't find so many of these fibers. This is too much, lots of fibers. And if we go to the top, there's also a lot of fibers. It's a bit too much, and some of the fibers are encroaching on the central vein there. So the tissue is becoming harder. And normally the liver is quite palatable, so if you push it, it's like soft, it's quite soft. But when it's cirrhotic, it becomes hard, really hard. And as it hardens, it means the mitotic process, the cells can't undergo mitosis as easily. And it puts pressure on the fluid movements through the caniculi, and eventually occludes or puts pressure on the blood vessels, so they can't bring enough blood to the tissue or the organ. We probably have to look at a high magnification to see more of the hyperplasia and atrophy. Okay. Do you have any questions?
No, I'm okay there.
Good. Good. Here we got some example of false lobules, lobular structures that are beginning to form. So there's lots of these little round ones where normally you'd have a big lobule. There's lots of smaller ones being formed. This one on the left is a big lobule, but these ones have got lots of little lobules, which is a bit abnormal, if you like. Well, the connective tissue is increasing in size between the smaller lobules and the bigger one. Some more there. Okay. Now as these smaller ones grow, they don't have in the center a vein anymore. It's supposed to have a vein in the center of the lobules. Okay. Right, but they're starting to lack that. So what's happening is the cells are trying to, if you like, increase their number in order to deal with the pathology. And if it's cirrhosis as a consequence of ascites due to drink, it means the cells are trying to increase their activity, and they, in order to deal with the alcohol or the poison or the toxin, so they divide more, and it produces all these little false lobules, or what your professor called of lobes. Eventually it's going to cause a problem, because the cells will lack, as the lobule grows in size, they'll lack nutrients, and some of them will start to die. And in order to prevent that, we get fat accumulation that starts to occur as well as the cirrhosis progresses, to kind of like, if you like, prevent or to seal up the necrotic areas. But the liver is very good, because you can cut away most of it, and if 1/3 remains, it will regenerate itself in terms of its anatomy and function. This example of carcinoma, a very dangerous form of cancer, as it can easily spread in the bloodstream. Remember, the liver is highly vascularized, lots of blood supply. And the malignant cells, forming trabecular structures with central veins and fibrous septi. Good. So here we got right there, if he asks you where's the central vein, this one is a central vein, yeah? But all the tissue around our central vein has started to degenerate, to form lots of spaces here. Lots of spaces. And this is due to the abnormal cell division as a consequence of the tumor. And this whole area is the tumor, tumorous tissue. Okay? This here is an example of a trabecular structure there, but it's really shrunk in size there, okay, and collapsed. There's a lot of fiber that's beginning to remain though, as a result of the death of the tissue. So eventually you get mostly fibrous mass, and the tumor becomes a big fibrous mass, if you like, hard mass. So it's quite a good slide, very good slide of the kind of like the atrophy as a consequence of the carcinomic properties. Here's an example of a collapsed structure there. Okay, we had our example of a vein. This is a collapsed, like trabecular. It looks like a trabecular structure. It could also be associated with some blood vessels as well, because I can see some examples of capillary red blood cells or erythrocytes. It has collapsed on itself, but notice the big spaces and the abnormal cell division. See, the abnormal cell division, it's all haphazard, if you like. It's not grouped together as a tissue, it's all haphazard. And that is typical of carcinoma, if you like. You got a question? Have you a question on this?
What is a trabecular structure?
Forming the trabecular structure. All right, yeah. The trabecular structures are there in the liver to help channel the bile, for example, to help channel various things like mucus, bile, secretions, etc. But with the carcinoma, it causes these structures to, instead of staying open, they collapse. So it blocks them. And if you block those things, and if you block, say, the bile caniculi, it means it builds up with bile, and that can cause all sorts of problems with digestion. So you've got loss of wall. To summarize, you've got loss of the wall of your vein. You've got a collapsed trabecula with probably a destructed vein over here, probably, because I could see some red blood cells. You've got overall abnormal cell division and big spaces forming. Okay, and the cancer here is classic with the big spaces that have formed, hardened structure, fibrous tissue trying to surround it. The cirrhosis can lead to cancer, okay, if left untreated. So we saw before in the cirrhosis the loss of lobular function surrounded by lots of fibrous tissue, lack of a central veins, if you like. Notice how closely the cancer is connected to the cirrhosis, and it looks like it's migrating in clumps. So there's one there, one there, one there, one there. So it's spreading. It's spreading into the tissue. Some examples of some normal cells still there, but eventually it's going to be degraded by the tumor. Micronodular, micronodular cirrhosis. Yeah, the nodules is the small little foci, the small little points of the cirrhosis that results in tissue destruction. You can see some there, there, there. I'm starting to see some lipid formation there and there. It's beginning to form. So the little nodules forming, excuse me, are trying to, in a way, they're trying to, the macrophages are trying to kind of like isolate this pathology, if you like. It forms these nodules. Problem is that the nodules block normal cellular function. Yeah, notice the color difference. This is very abnormal cell division. This is normal cell division, but being damaged by cirrhotic changes. Adenocarcinoma of the colon, yeah. Large tumorous glands on the right bottom, yeah, large spaces. No production of mucus, or what he calls mucin. Normal colonic mucosis upper left. Yep, these cells are normally dividing, normally producing mucus. The colon needs a bit of mucus to help movement of the feces, but also the structure of the colon here is normal because it's allowing the absorption of salts and water, as is its main function. The tumor seems to have started up this end here, and it's sort of migrating its way towards the surface here, okay, causing massive destruction of parenchymal tissue. Some examples of normal tissue there, but breakdown there, large spaces, lots of cellular debris, a bit of bleeding. Okay.
Okay.
Adenocarcinoma of the colon, a bit of a higher magnification. Large tumorous glands on the top, and totally without any ability to produce any secretions. There's a lot of cellular debris here, broken down cells all over, huge spaces. Examples of bleeding over here. Whereas the bottom part is still the normal type of cells, right, with their normal luminal spaces. Right? They'll be producing mucin, mucus, and helping the absorption of water and salts. Eventually, this tumor is going to hit these. It's going to infiltrate these areas. Okay.
What's dividing the normal areas and tumors?
Okay. This area here is fibrous tissue, and it's trying to, an attempt of the body, and trying to encapsulate the tumor. So it's trying to prevent the migration of the tumor further. And this is why a lot of the tumors are quite hard to touch in pathology post-mortem, because the capsule is really hard. So this is an attempt of the body to isolate the tumor. It's a dangerous one, adeno. Why is it dangerous? Because it can easily spread from the colon into the bloodstream. Okay. Good. Large tumor glands without mucin production. Yeah, definitely, yeah. See all the cellular debris here and the breakdown of the surface become very rough and abnormal. Over there, cellular debris, it's abnormal, lots of fissures, if you like, what you call tears, abnormal. Should be more roundish or elongated, not so rough. Cells showing distinctive signs of cellular and nuclear atypia. Yes, the cells are all over the place. See, they're all bunched all over instead of being uniformly bunched. There are some that are still uniformly bunched, but most of them are all over the place. Okay? See, all over the place there. And that's totally it's going to disaffect the function of mucus, mucin, production and majorly disrupt the absorption of water and salts. Okay, eventually all this tissue is going to die and become necrotic as the carcinoma progresses in its pathology. Large tumoral glands without mucus production. Yeah. Some moderate differentiation, cells showing distinctive signs of atypia. Again, you can see it's an example of some cells still having a fairly normal array of nuclei and a sort of a roundish, that's kind of like round you'd like, but cellular debris is accumulating, the rough border forming means that it's degenerating. And all over, there's loss of cell function, if you like. So the nuclei are becoming abnormally divisive. They're dividing atypically, if you like. And yeah, it's sort of a loss total of function. Perhaps this, if the professor asks, is any normal? Perhaps this one is still a bit normal. The nuclei are still in their normal pattern, roundish pattern with a round or elongated lumen. But most of the areas here are abnormal. Some fibrous tissue infiltrating to try and localize the carcinoma. Okay. Okay, so the renal failure. This is a Bowman's capsule. You can see lots of tubules here in this section. It's hard to see. There's only a few blood vessels, not a lot. Perhaps only here in this glomerulus can you see a few of the vessels. Okay. There's a lot of, sorry, this mouse. There's a lot of darker areas forming. This one is necrosis, necrotic areas. Okay. I'm trying to see if I can find some other necrotic areas, perhaps starting to form.
So the necrotic areas are the darker ones?
Yeah, the darker ones. And notice there's fewer cells dividing in the tubules. This one is quite good. There's quite a lot of cells, but if we move down, there's lots of cells there, less cells, less cells. So the tubules are degenerating. So in the nephron, the actual loops and the tubules are breaking down. They're not dividing. They're not being maintained. He says the proximal tubules, their cytoplasm was darker and more eosinophilic than the epithelium. So let's see if we can find a darker cytoplasm. Yes, here. Looking for a nucleus, just look for around it. There's a bit of darker cytoplasm there. Okay. All right. Can you see that just over there? There's one example there. Okay. As it's acute, it means the disease has just almost started. It's not chronic yet, so it's like some misfunction in various places, not all over. Okay, so some of the areas are working, some aren't, if you like. What worries me here is this area. There's a lot of thinning of the wall, massive space. It shouldn't be this big, and loss of these cells with the nuclei. So the wall is really thin there. You can see how thin it is there. Thinned, really thinned. There's a normal nuclei there, normal nucleus, but here there's a loss of that. And another dark patch of necrosis forming there. So this is pathology. Yeah, I think that's about. You might want to mention that the the membrane or the capsule has a normal conformation there. It's normal around there. It's fairly normal. And the space in the Bowman's capsule looks a bit normal. However, there is some debris forming, but it looks fairly uniform in terms of its bow shape. Okay, here we have another slide. Now, this is sort of normal striations, but first of all, in acute renal failure, we're losing lots of nuclei, lots of their function. Okay, so can we look for, first of all, the loss of nuclei, and secondly, can we look at for the thinning of the walls of the tubules, and finally, can we look for necrosis? Okay, now this is a very nice Bowman's capsule. I can't see much pathology there. Very nice membrane, very nice space, not much pathology, but it's actually the tubules that are in the central area that are being affected. So let's see if we can find here loss of nuclei, thinning of the wall, okay. Here, breakdown of the nuclei, the cells. Here is a very good example of thinning of the wall in this tubule, and it's totally been disrupted. Won't be able to exchange salts, won't be able to reabsorb glucose, won't be able to handle urea, etc. So what happens is your acid starts building up, your salts start building up in the bloodstream, causing all sorts of problems, blood pressure, metabolic acidosis, and later alkalosis. Towards the top, there are some areas of 1 or 2 normal cells, but degeneration quite close to them. So this is, yeah, definitely fairly advanced acute renal failure. Fairly advanced, yeah. Okay. So the patient is able to filter if we assume that the glomerulus is fine. But once the filtrate gets into the tubule, the patient's unable to deal with the filtrate. If you get what I mean. See? Yeah.
Yeah.
Very good. This is more of a normal kidney because, again, the glomerulus is a normal conformation, a nice bow shape, and mostly round and roundish in shape, and also lots of nuclei, lots of red blood cells, lots of capillaries, fairly normal structure there. The tubules, well, I don't know whether it's all that normal, but a fairly roundish conformation of the cells. So yeah, that's a normal set of cells there. And a uniform around. There's no thinning of the wall as such or loss. That's normal. I think this tear is from the sectioning, mainly the sectioning there that's happened. Yeah. As I can see some artifacts here on the slide from the staining as well. So yeah, so it's fairly good. The best example in this slide is the glomerulus, normal glomerulus. Glomerulonephritis, rapidly progressing GN. Yeah, the loss of, eventually what happens is the breakdown of your glomeruli. This is still a fairly normal glomerulus. This one is degenerating, starting to break or collapse. Some of the others have totally collapsed. Here's one, here's another, totally collapsed. And notice the loss generally throughout the tissue of your tubular structures. You've got some still remaining. This one is still there, fairly normal, but big spaces, loss of them. These are degenerating. Got some blood vessels there, but generally you're getting some spaces forming in the renal tissue, which is abnormal lumens forming, breakdown of the tissue. This is necrosis. Yeah, can you see the darkened areas here? This is definitely necrosis. Yeah. And all sorts of problems can result, including death of the patient. Okay. All right. Any questions on that, sir?
No, we can move on.
Good. Okay, here, rapidly progressing GN, yeah. And here you can see the total destruction of your glomeruli that collapsed. It's still got the round form, but the wall has collapsed. The Bowman's capsule has collapsed, and there's spaces forming where the knot of capillaries or ball of capillaries was. So they're also beginning to break down. So the membrane diffusion has been severely affected. We've got an example of blood vessel there. They're fairly normal, but this one is broken down due to the darkening area of necrosis. This is the necrotic tissue there. Necrotic tissue, usually around the spaces that form. So the cells are actually beginning to die in the kidney. Okay, and that's due to the accumulation of toxins because the kidney is unable to filter out to deal with the toxins, if you like. And
why is the white space around the blood vessels?
oh yeah, this space here, the spaces, yeah. Okay. It's a luminal space. I don't see any example of a clot there. I think that's just because I suppose when the tissue was processed, that the erythrocytes clump together, if you like, so they're causing the space. I don't think that's a pathology because the membrane is still intact. The membrane is still intact. This one, the membrane is ruptured, it's broken. This one, the membrane is actually broken and it's bleeding. It's causing bleeding into the tissue. This one is necrotic tissue, all cellular debris.
Do you know which blood vessels they are? Or?
This one is an artery. This would be an artery here. Definitely an artery. Looking for a vein. I can't see. Yeah, this one is a vein, thinner walled. This is the thinner walled vein here. Thick walled artery. Thinner walled vein. Yeah. Necrosis, by the way, before I go on, necrosis is also beginning to form within the collapsed glomerulus. As we can see, the darkened patches forming there. Not too much, but some necrosis. The crescent structure. So this is collapsed, if you like, glomerulus, if you like, and total loss around it of tubules, spaces forming, all spaces everywhere as tissue starts to die away. So generally, a total loss of cell function, if you like, inability to filter. Inability to filter, secrete, and reabsorb. Yeah. Oh yeah, necrosis is definitely there. That's necrotic tissue. This necrotic tissue is there. And a bit over there. So the crescent. This is one guy that's struggling. He's struggling a bit. His glomerulus is still fairly functional, as he's got a good Bowman's capsule, but he's struggling because there's bits of the membrane beginning to break down, necrose, beginning to necrose. This one has completely lost its function. And all these crescents begin to form. Eventually, this is going to become necrotic with time. Yeah, about that. I think that's about it, really, in there. Yeah. Yeah. Slightly better slide as the contrast is more clearer. The main reason, although you've got a fairly normal glomerulus, you've got a vast loss of tubular structures, but particularly the breakdown of cellular connections in the tissue. As you can see, the fissures that result. Patches of necrosis forming there, and this space will eventually widen. Chronic glomerulonephritis. Okay, this is the more serious condition. It's obviously a long-term condition, but the tissue becomes hyalinized or kind of like abnormal structure, and hyalinized tissue is a tissue that is more impermeable, if you like, to the flow of fluids, and it interferes with tubular function. So you got all these crescents here, lots of more crescents in the tissue, loads of them. He says uremia. There's a lot of accumulation of urea in the tissue. And urea can revert to ammonia if left standing. Now we do filter our urea and we pass some of it out. We filter our creatinine as well from our muscle metabolism and filter it out. But in chronic glomerulonephritis, we tend not to excrete as much, and it tends to build up in the tissues. And both of those collectively can result metabolically in formation of ammonia. So you get what's called metabolic alkalosis, and as the ammonia breaks down, you get then metabolic acidosis, and those two, acid and alkali, are tissue destructive. As you can see, the whole tissue here is breaking down. Lots of spaces of non-functional tubules. Yeah, it's very serious indeed. Yeah, I can see the breakdown. You can see the edge is all rough. Lots of holes. Perhaps about one. Looking on the slide, about one fairly normal glomerulus. The rest are finished. They're sort of non-functional. Huge holes, lumens forming. It's peppered with all these holes. As the condition progresses, more cells are dying. Lots of urea, lots of acid, lots of inflammation. Because you're getting bacterial invasion as well. As the tissues die, you get lots of bacterial invasion. And some examples of necrosis there. This is sort of necrotic tissue there. Yeah. Eventually, this kidney will become non-functional. Eventually. Nephritis, pyelonephritis. There's the problem with this is that it can cause damage to the glomeruli. Acute can be treated if done in time, but generally these glomerulus start to become inflamed. Okay, and as they become inflamed, eventually their membranes are disrupted and can cause some collapse of their structures. I can still see, however, in this condition, some normal tubules, fairly normal. No holes, good cellular structure, good luminal conformation. There's some normal ones there. It's more around this collapsed one here that we see loss of some of the tubules. Not really much necrosis, maybe one or two spots of it up here, but not a lot. Okay. Interstitial inflammation, infiltrate, or polymorphonuclear leukocytes, and small abscesses. Yeah, so the abscesses are a consequence of cell death, and the abscesses are also a consequence of macrophage action as well. You get pus formation. So let's see if we can identify the inflammation, areas of inflammation, and the abscesses. Okay, so excuse me, this whole area here is inflamed. Okay, there's lots of cellular debris, and with inflammation you get lots of cellular debris. Here we're having a lot of activity here. Okay, so lots of white blood cells. I would say leukocytes, macrophages working together to attack infective agents in this area here. The small abscesses that result are sort of spotted around. So let's see if we can find some. So blood vessel. Sort of a bit of an abscess there. Abscess.
Yeah.
Little one there. Abscess. Moving down. Oh yeah, there's some good ones here. Actually, probably focus your tutor, your lecturer on these. These are abscesses here. These ones. And there's a good one here as well, right at the bottom. Yeah. Yeah, that's I think that's about. If he asks you, is there any normal? Yeah, these tubules are normal because the walls are still intact. The nuclei are still okay. The cells are still intact. The lumens are still normal shape. Yeah, so it's like spotted in certain areas. Acute pyelonephritis, inflammatory infiltrate, slowing death of tissue, massive here, loss of glomerular function. This tissue is really in a serious state. Lots of abscesses. One there. There's one there. Dotted around. This one is a good one here. However, there is some normal tubules still remaining and a normal glomerulus. This top area, though, is really seriously infected. Any questions before we move on that one?
That's fine.
I think we can. Small abscess. Well, we can see more the inflammatory reaction. The inflammatory reaction here and over here. There's a lot of accumulation of cellular debris, inflammation in this area here. As for abscess, you can't see one very easily. Perhaps there's a slight abscess there. A normal glomerulus there. Okay.
The polymorphonuclear leukocytes. Which ones are those again?
Polymorphonuclear leukocytes. Oh yeah. They would be involved in the inflammatory reaction that we're seeing here. The secondary attack. So the macrophages first, and then the leukocytes, and the leukocytes are causing these areas of inflammation. Yeah.
So the darker color ones are the leukocytes.
Some of them, yeah, not all of them. We'd have to have a higher magnification, but they dotted inside there, yeah. Some of them are the leukocytes, yeah. Some are the macrophages. Some are the leukocytes. You probably have to have times 1,000 or 1,500 magnification to see them. Again, a similar example of inflammation. This is massively inflamed though. This area here is hugely inflamed. All this is the leukocytes, inflammatory infiltrates, some normal tubules towards the bottom here, normal tubule. normal tubule. Fairly normal but degrading Bowman's capsule, beginning to degrade because there's a shrinkage of the capillaries as well. Oh yeah, here's a better magnified acute of the white cells, and here, like I said, here there's the inflammation all in this area where there's lots of accumulation. So let's see if we can find our leukocytes. Okay, so here's a leukocyte. Sorry, beg your pardon. Here's a macrophage. There's a macrophage there. The macrophage.
Yeah.
Here is a leukocyte here, more of a round nucleus. It's less darkly stained than this. This is darker stained. Less dark. This is the leukocyte there. So point in the middle there, macrophage, and there's another one there, leukocytes there. I can't see many neutrophils as such, but perhaps that's, yeah, you don't really need to mention the neutrophils. I think just the leukocyte.
Yeah.
So more there. There's another one there, another one there, another one there. These are the slightly lighter nucleated cells. The chronic condition as well, inflammation is massive. There's all the inflammation here, all these sort of purpley dotted bits is inflammation. Big spaces forming. Some of the tubules are still okay, but what I noticed mostly is the shrinkage of the glomeruli starting to shrink. This is more of a normal size. Breakdown of the ball of capillaries. So yeah, very, very inflamed tissue there overall. Dilated tubules, lymphocytes, pink portentous matter. The portentous matter is the cell debris that's forming. And we saw yesterday the stromatization. Stromatization is like or collection of this pink material, like cellular debris. Can we find some of the lymphocytes? Let's see if we can find them. So I said that there's slightly lighter nucleated cells. Here's one here, there. Across, there's another one there. There's another one there. They're everywhere. You look closely, they're dotted and almost there, everywhere. Yeah. Massive invasion of lymphocytes and big spaces forming as a consequence of the death of tissue. So we're almost time up. Let's move on to one last slide. You get the surface of the structure beginning to degenerate, break down with lots of holes forming, necrotic patches. Some areas, perhaps that area is still a bit normal, but most of it is rough, broken down areas. Okay, massive inflammation. There's all this purple dotted bits is inflammation all over.
Which part is the submucosa?
Sorry?
Which part is the submucosa?
Oh, the submucosa. The submucosa is just, so this is the mucosa, and the submucosa is just below it, there. This is the submucosa. Okay. That's, I can see one or two normal tubules, but most of them are degenerating. Some normal ones on this side. But this is not normal. Big spaces everywhere. No. Okay, so I think that's the 1 hour. Looks like one.
If you could do one more lesson on Wednesday, if you're free that day.
Wednesday.
Wednesday, yeah.
What times? What time does that be?
Same time,
Same time?
or
Okay,
if you're busy.
Stay. Let me just check my diary here.
Yeah, that's fine.
Yeah, it's fine. Wednesday's fine. Wednesday's
Fine, and on Wednesday I'll be able to on Wednesday by Zoom I'll share my screen because I'll be able to magnify some of the slides.
Okay, no problem. Yeah.
They'll be like the same titles like as in this document, but I'll be able to magnify it more.
Okay.
So Wednesday 11 a.m.
11 a.m. Yeah. Were you able to record it, or should I send you this?
Could you send me this, please?
No problem. No problem.
Thank you so much.
Okay. Good luck with your studies, and see you soon.
Yeah, Wednesday. Goodbye.
Bye.